Hello, everybody, and welcome back to the Lube Tube. This is episode 9 called Hot Flashes and Hormones and What's the HRT Buzz? This is Jeanette and my co-host, Brittany. Ladies, she just got mad at me because I said my last name and she just wants to be like Brittany. Nobody needs to know her last name. She's like kind of like Beyonce or Madonna. Mm-hmm. What is that called when you just go by one name?
Famous.
Okay. Anyways, welcome back, guys. I'm really excited about this one because we're going to be talking about the different types of hormone replacement therapy and also non-hormonal options too. I know I've had a lot of ladies ask me, are there only options that include hormones? And there are some really good ones out there that we're going to talk about that are non-hormonal based. But the main goal of this is to educate you. And so you can have some tools to take to your provider and basically be educated on it before you have that appointment with them to talk about different options that fit your lifestyle. So here we go. Let's go and talk about what actually happens during menopause, perimenopause, and kind of what is happening during this time. We go our whole life with fluctuation of hormone, right? Obviously, every month, just like we talked about during the menstrual cycle episode, our hormones go up and then they go back down. Well, now during perimenopause, they're not quite following that normal up and down. They're kind of going all over the place and they are kind of wreaking havoc on us as females with all kinds of different symptoms. So you may feel PMS-y the whole month, right? Which is obviously no fun. And then menopause is the complete stop of that hormone fluctuation. So we go our whole lives with this fluctuation. We go our whole lives with these hormones, which include estrogen, progesterone, and testosterone. And now they are completely gone, right? So my goal for today is to kind of educate you on that, to teach you how we can make you feel better during those times and what options that are available.
Right. And there are options that certainly are not given to women by some, I'm not trying to throw people under the bus, but
sure,
by some providers, because menopause is still one of those things, and perimenopause, that is hush hush. Let's not talk about this.
Absolutely. But I don't know about you. Well, you're antisocial, Brittany, but social media, there's a huge buzz about hormone replacement therapy. And it's probably because my feed is basically full of that because I talk about that and I look at things up and I read about it. And obviously the bots are looking at me and following what I do.
I know.
Right? Pretty scary. Anyways, we got rid of Alexa because of that. Do you have an Alexa?
Unfortunately, I just got one.
Oh,
I don't know how I feel about
Sorry.
it. No. I'm very much on the fence because I just feel like I'm being listened to. But let's be honest, our phone is
I know.
doing
It's
the same thing. Our
thing.
TVs do the same
You think
thing.
So? Ooh, that's scary. I didn't think about that.
I have some people that really have gotten some conspiracy. Obviously, I talked about conspiracy theories last episode, but we can talk about TVs listening to us if you want to. Like, why did my TV in my room just randomly turn on?
Really?
2 nights ago.
Paisley didn't hit the remote?
No.
Paisley's her dog.
No. Yeah, no, she did not.
So we took ours down, our Alexa, because I was starting to notice that everything Daryl and I were talking about just in normal day-to-day life in the kitchen, it was coming up on his feed, it's coming up on my feed. I don't know, it kind of freaked me out. So I got rid of it. But now I should probably just pull it out since we have smart TVs everywhere.
Exactly.
My husband's addicted to televisions and our cell phones are right there too.
Mm-hmm.
But anyways, going back to what we were talking about, it's literally becoming more talked about. And I love that for women. For the longest time, nobody talked about menopause, perimenopause, and how to treat it, what it is. We were just expected to, hey, your hormones are over. That was fun. Now good luck with the rest of your life. Well, it doesn't have to be like that, right? I watched a really good, what would you call it?
It was a documentary.
A documentary. Yeah. And I shared it with Brittany too. And I will actually put it up on our Instagram because I think every single one of us needs to watch it. And it talks about just how medical doctors, people who go to school for this, who are trained in women's health, have very little to no training on the menopause life and the perimenopause life. Most of their training is during the reproductive years. So the periods, the having the babies, the miscarriages, the losses, and then how to get somebody pregnant and basically how to deliver that baby. But a very few or very little of their training is actually on the perimenopause and menopause life and what to expect after reproduction, right? So I'm excited that people are talking about it. I'm excited that physicians want to educate themselves. Also, non-physicians like physician assistants and nurse practitioners are learning more about this to help these women, because I think it's really impressive that most of the working force, right, of this huge company that they interviewed, they said that I think it was like 55% of their women were 45 and up. Well, guess what? Those women are all perimenopause to menopause. And so they had all of these benefits insurance-wise for these women for reproductive years, but didn't have any insurance benefits for these women who were going through this. So they changed their whole thought process and now provided this whole way of help for all of these ladies to get, whether that was counseling or therapy or...
Right, it was menopausal coverage.
Yeah, menopausal coverage. How cool is that?
That's very cool. Very cool.
So I love that it's being talked about.
Yeah. And another thing that they touched on in that documentary was the things that we go through that some people don't even know, like, what is this? Like, why do I feel like a different person?
Right.
And those things that we've definitely talked about it in other episodes, but hot flashes, night sweats, these mood swings, not being able to sleep, the dryness, the weight gain.
Yeah. The joint pain.
Yeah. Joint pain.
The cognitive function.
Decreased libido.
I mean, it's insane how much this transition causes side effect, right? And symptoms. As far as women that come to me, I start naming these off and they're like, check, 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 check. And the amount of times that they've been written off by other providers, right? And said, oh, that's just age.
Well, and sometimes I feel like those providers may be writing them off because they don't know how to treat it.
And
right?
I think that's exactly what it is.
Which goes back to what we were saying, how the training wasn't there.
It wasn't there. And it's no fault to them, right? They just truly were not trained on this, which is, I'm sorry, it's such a disservice to the females, right? But I'm trying my best to stop that, okay? I'm pioneering this.
Yeah.
Oh,
You're
man.
so great.
Thank you. I'm really trying one patient at a time.
Let's also talk, though, about what it does for our bones.
Oh, yeah. Yeah. So osteopenia, right? Which is the breakdown of the bone. That's the loss of density, right? So a little bit more brittle. So if you were to fall, you might break a hip or break a bone a lot easier. And then there's the transition to osteoporosis, which is the complete breakdown of that bone. So estrogen and testosterone are very good for bone health, right? And so as we lose those, our bone density goes down, which in those situations, we recommend, weight-bearing exercise and we recommend hormone replacement therapy, but also calcium and vitamin D. So they play a huge role, right? All these hormones. And when we lose them, lots of things go down. There are estrogen receptors all over our body. They're in our brain, our guts. They're in our bones. They are everywhere. So anywhere there's an estrogen receptor, we are going to be symptomatic when it goes away.
Right. And those are cardiovascular.
Oh yeah. Huge
Component as well. Yeah.
Absolutely. And, thank you for bringing that up, because cardiovascular disease is actually, for females, our number one threat. It's not breast cancer. It's not ovarian cancer. It's not cervical cancer. It's cardiovascular disease. And studies have proven that the sooner we start estrogen and progesterone and hormone replacement at that, after menopause or during menopause, that the better your risk assessment is moving forward. So it actually can be cardioprotective.
Okay. Good. All right, let's just jump in.
Okay.
Let's talk about the hormone replacement.
Okay.
And
talk about that first.
What this really is.
Yeah. What does this entail? So you have options, right? Like we talked about, there's three main hormones. There's estrogen, there's progesterone, and there's testosterone. Estrogen can be given alone as long as you do not have a uterus. Okay. So if you have had a hysterectomy, then you can get estrogen by itself. If you still have your uterus, meaning you haven't had a surgery to remove it, i.e. the hysterectomy, then you have to take progesterone along with the estrogen. And the reason for that is because they have to be balanced in order to keep that lining of the uterus from building back up, okay? The lining is what we bleed off every month with a period. And if you give estrogen alone, there's nothing there to thin that lining and prevent overgrowth or overproduction of that lining, which then can lead to abnormal bleeding after menopause, or even worst case scenario, endometrial cancer. Okay. So you have those two options. Can someone take progesterone alone? Absolutely, right? That's no problem. Progesterone a lot of times is used to help with insomnia, especially micronized progesterone. It's the one that's most like our compound in our body of the regular progesterone that we make. But it can be excellent for the use of insomnia in females. As far as the progesterone alone, there are some perimenopausal women that just take progesterone alone just because it does help with that sleep cycle. It can also thin that lining to the point of makes your periods and that abnormal uterine bleeding that can happen during perimenopause a lot easier on you too.
Right. And then the testosterone.
Yeah. One of my favorites.
Yes. Well, and a lot of people say testosterone.
Mm-hmm.
No, I am not a man.
I know, right?
But that is not the case.
Mm-mm.
We do need testosterone.
Yes.
I mean, that's the basis of what I do
all day.
Mm-hmm. And when we were in our early 20s and living our best life.
Right. That was fun.
I don't know if that was my best life.
Really? Early 20s?
Yeah.
No, I would say
maybe hormonally. It was my best life.
Hormonally, right? I was like rocking it.
Right. I think that, yeah.
But I would say best life, late 20s.
Oh.
Early 30s. 30 was the new thing. I'm 40 now. Damn it.
No, but 40 is the new 30.
You keep telling me this. I think you're just going to tell me that at 50 and then 60 and then 70.
Because
just keep believing it?
Yeah, you gotta say it to believe it.
Okay, got it.
Okay, guys, back to it. So when we were in our early 20s, our testosterone was anywhere from like 60 to 80, potentially higher.
Yeah. Absolutely.
When I check the labs of my ladies that come in, I'm lucky if I see a testosterone that's above 20. And we're talking people that are perimenopause.
Yep. Mine was less than 12. Mine was 0, remember? And I checked mine, how old was I? Probably 38. 38 when I first got it checked for the first time. And testosterone, we start losing at 26 years old. That's really young, right? That's prime time, right? For most women. And that starts to go down. And some of the biggest symptoms I think that people report with the loss of testosterone are the night sweats, right? The night sweats, the decreased libido, the brain fog, and they're going to the gym every day, but they just don't feel like they're making that muscle like they used to be, right?
And the fatigue too.
And the fatigue. Yeah. And I think a lot of times that's written off as, especially if they're in a career driven, if they're busy, maybe they even have kids at this point and they're going a million miles an hour and they think, oh, I'm just tired, right? I'm burning it from both ends. I'm just tired. But honestly, it could absolutely be a hormonal issue.
Oh, definitely. And that's a nice thing for you to note, that the decline can start very early on. So you don't have to be in your 50s or 60s to be like, oh, it's time for hormone replacement.
Really
There are certainly different types of replacement that can happen that can improve your quality of life. Because when we really boil this down, yes, it's about making sure that we have good cardiovascular health, that we have good bone health. But this is also a quality of life thing.
For sure.
Where when you're in a room with people, you're not the most miserable one there.
I know.
Right?
Right. And women have been basically told that this just is how it is and this is how it's going to be. And you just have to live with it. And no, I'm good.
No thanks.
No thanks.
No thanks. Okay, let's talk about the different forms of hormone replacement.
So estrogen, if we want to talk estrogen first, that comes in a couple different forms. First one that is well known is just the oral tablet, right? Just an oral estradiol that is different than a birth control, okay? So an oral estrogen hormone replacement is different than the type of estrogen that is used in a combination birth control. So being on oral estrogen is not going to prevent you from getting pregnant if you're in the perimenopausal period, okay? So I think that's important. So if you go see your doctor and you're perimenopausal, meaning you're still getting a period every once in a while, and you still are in that fertile window, you absolutely need a form of birth control along with that, whether that is something hormonal or something that is like a condom or pull-out method, whatever that is, right?
Hold on.
Okay.
You just hit a button for me.
A pull-out method?
Pull-out method.
Yeah. Yeah.
I have
pull and pray.
Pull and pray. Thank you. I think it's interesting that you're saying pull-out method.
Why?
Because I just have had multiple friends that have
gotten pregnant
with the pull-out method.
Yeah, it is not 100%, not even 50. So that's
Thank
not
you.
my form that I'm going with.
I'm just saying that felt like an endorsement for the pull-out method.
Okay, I do not endorse pull and pray. If you want to pull and pray, go girl. Okay, but that's not my jam.
Okay. Thank you. Thank you for the clarity, because I know I'm going to have some friends that message me and be like, oh, Jeanette supports me.
No, I strong.
It's just not this. It's not the
most effective.
Yes.
That's how we'll say that.
Yes.
Okay. Okay. So back to that. So an oral estradiol. So remember, if you still have your uterus, you have to be on progesterone along with that. The other part, or the other option, is a transdermal patch. This is my favorite, okay? If we have to talk about something that is covered by insurance, right? The estradiol patch is a small dime-sized little patch that goes on your abdomen, and you change that sticker that's good in the water. You can go swimming, you can bathe, you can do all the things. You change it twice a week. And that allows the estrogen to go through the skin, what we call a transdermal approach, and it goes systemically through the system, basically helping all the symptoms that we just recently mentioned. I really like this. This is covered by insurance. It is, my favorite is either the Dottie or the Vivel patch. They are two different brand names, and they work very well. What I like about them is that they're so small, right? You can still wear your bathing suit. You can still, they're clear, so they're hard to see. The generics are a little bit larger of a patch, and I see more skin irritation with those than I do the Vivel patch and the Dottie. So just so you know, I mean, if your insurance doesn't cover those brand names, maybe you can try the generics first, and then your doctor can write a letter of medical necessity due to a skin allergy. Just a hint.
And there's also fewer risks for blood clots with the transdermal,
That's
correct?
exactly right. So, oral estrogen, there is a cardiovascular risk there. The reason why is because it has to be bypassed, or it has to be metabolized by the liver, which then changes the component of that estrogen, which then puts you at increased risk for blood clots, which then puts you at increased risk for cardiovascular disease like heart attacks or MIs or even strokes, right? So going a transdermal approach is absolutely the safest. Very rarely do I start somebody on oral estrogen. If they come to me and they need a refill, we talk about the risks, we talk about the effects of estrogen. And if they're okay with being on the oral estrogen and continuing with it, then I refill it. But a lot of times I will try to educate them to see if they would feel more comfortable going the transdermal approach.
Okay.
There's also topical gels, which I also like. Brand name on the market that I use for this one, there's a couple of them, but one off the top of my head is called Divigel. Divigel comes in a bunch of different doses, and you apply this gel, very small amount, to your inner arm or inner thigh once a day. That also has the transdermal approach, so it does not have that increased cardiovascular risk. But sometimes patients are like, I have to apply something every single day, and that is the downside of a gel, right?
Mm-hmm.
As far as progesterone, I know we talked about that. Progesterone comes in really multiple forms, but I'm going to just be very upfront about this. Really, the only type of progesterone I prescribe is going to be the micronized progesterone, because it matches our naturally made progesterone. And it is the only one that's been proven to safely protect that endometrium. So some people will prescribe a progesterone that is compounded into a cream. That's actually not protecting your endometrium as well as you could get with the oral progesterone. You also don't get as big of results of fixing the insomnia as you do with the oral progesterone. So I usually tend to stick with the micronized. And those come in two different doses that are prescribed at a local pharmacy, either 100 milligrams or 200 milligrams. You can get them compounded, an oral progesterone, to a sublingual, which some people kind of like a little bit better. And those come in obviously different doses than just what's prescribed at your local pharmacy.
Bioidentical.
Oh yeah, this is your jam.
Here we come.
Yes. So bioidentical, these are going to be derived from plant sources. So they're going to be more closely like the natural hormones that are made in our body. Bioidentical, a lot of times, are made of soy, right? Or plant-based. And these can come in different forms. They can be compounded at a local compounding pharmacy. And that you have to trust your provider to compound it correctly, right? Because when they send the script in, they are actually the ones that are coming up with that formulation for you. And then the compound pharmacy, depending on which one your provider chooses, or maybe you choose, you have to make sure that you trust that pharmacist is making that compound correctly as well. So there's a little bit more of a, what would you say? How would you say it? Like a little bit more wiggle room there, and more dependence on that pharmacist and provider to compound that correctly. Make sense?
Yeah.
Okay. And then this is Brittany's jam. So these are the pellets, right? Pellets are a small little size of a grain of rice, basically a hormone that is placed underneath the skin during a procedure that takes all of about 5 minutes. I don't know. You're pretty quick.
That's what they say.
Painless procedure though, ladies.
Yes.
Painless. The most awful part, in my personal opinion, is the lidocaine, right? Because we just can't make lidocaine not hurt. It is used to not hurt you while you're doing the procedure, but it hurts when you place it.
But wouldn't you rather feel that than feel? Yes.
Yes, 100%.
Yeah. And this is just a PSA to everyone listening. I guarantee you there's someone in your life who is doing pellets and just isn't talking about it.
For sure.
There are lots of perks to pellets. One of them is I give you a pellet and I don't see you again, and nor do you have to think about it again for 3 to 4 months. Some people can do 5.
Yep.
Kind of just depends on your level of activity and a lot of other factors. But I know that for my ladies who come in for the first time, they're a little apprehensive.
Of course.
Obviously. I mean, this is a hormone replacement. We haven't even gotten to why people don't want to do hormone replacement.
We're going to get there.
Be pellets under my skin.
Yeah. Can you take them out?
No, ma'am. That's a big thing. We cannot take them out. But the reason that I like pellets is because it is, again, bioidentical. Right. So there's nothing synthetic here.
Correct.
The particular pellets that we use actually are yams. There was a really intelligent person, I wish I would have thought about this again, I'd be so rich, who took a steroid ring of a yam and said, I can manipulate this to look like testosterone. I can manipulate this to look like estrogen, and then just compress it into a pellet.
Oh, I didn't never know that. Huh.
What a genius.
You are a genius. Oh, the guy is a genius.
Oh, but me too. Thank you. Thank you for all of that.
So tell me what hormones can go in a pellet. Like, can you get progesterone in the pellet?
No, ma'am.
Okay.
Progesterone will always be something that is given outside of the pellet.
Okay.
So typically, like you said, the micronized progesterone is what we're going to use. We're going to get either testosterone alone, or we will add that estrogen in. And that is obviously patient by patient.
Right.
And something that we will look at labs, we'll see what your symptoms are. And that's when we decide what exactly we're going to give you.
Okay.
Not everybody gets the same dose. And this is actually a hot topic because of insurance purposes, I should say, because pellets are not covered by insurance.
Right. Well, testosterone's not FDA approved in the United States, which is just crap for women, I should say.
But for men, it is, right? Because that's their hormone.
Yeah.
That's what I call bullshit.
I agree.
Right? So our men that are getting injections, covered.
Yep.
Our women who ask about injections would never be covered.
Nope.
Nor do I really love that for women.
No, it's not my favorite either.
Yeah, it's just, I feel like you don't have the proper control.
Right. And I just feel like you have too much up and down with that.
Yes, exactly. There's no consistency there.
Right.
But the FDA is trying to approve a pellet.
Oh, look at this.
But it would be one singular dose for every
of course.
person.
Because everybody's the same.
Right.
Right.
Absolutely not.
So irritating.
If we really start to talk about our healthcare system, even though we're completely 100% in it.
I know, all day.
I want to move to Europe.
Oh,
honestly.
That would be nice.
They are so far ahead of us in so many ways.
I know.
It's really very frustrating.
I know.
But pellets are a great option.
I agree.
For our ladies that are going through these symptoms, whether you're perimenopausal or menopausal.
And you also add estradiol low dose for the perimenopausal or even the ladies with migraines, right?
Definitely. If someone is coming in and they've had hormonal migraines their whole life, I can change their life by
Wow.
giving them just that small dose of estrogen.
It's just nuts, right? It truly is nuts because by giving that, I think it's only like 6 milligrams that you give in a pellet. A lot of times when they're still perimenopausal or even premenopausal, that estradiol, when they come back and see me, they'll tell me, yeah, Brittany gave me 6 milligrams of estradiol in that pellet. And it really actually got rid of my headaches. I haven't had migraines in months since I got that. So, and also can help with some of the hot flashes that happen early on. So
absolutely.
I think that's pretty awesome.
Yeah. And again, I think talking again about quality of life and how I have some patients that come in and you can just see it on their face. Like they have been spending the last year of their life, the last 5 years of their life, just dealing with these things.
Yep.
And they come in and say, hey, this is my last ditch effort. I don't know what else to do.
Yeah.
And then I'll see them 4 months later and literally their life has changed so dramatically. They can't give me enough praise. And I've literally done nothing. I've just done what I've learned to do.
Yeah.
But they just had nobody else to give them this. Like,
that's huge.
This gift
it's
of
huge.
Like, give me my life back.
It's huge.
You know, give me back when, like, how I felt 5 years ago.
I know.
How I felt 10 years ago. How I felt 20 years ago.
I know.
You know? And that is, I think, people often ask, you've been doing this for a while. Does it get boring?
No.
I'm like, no. Because the difference you can make in someone's life is, I mean,
it's like such a good feeling.
Yeah.
I saw a lady late last week that she was terrified of hormone replacement therapy when she saw me. We had a long talk about risks and benefits and kind of options. And I put her on the patch oral progesterone, and I gave her actually a topical testosterone cream, which we're getting ready to talk about that. And she came back, Brittany, and she hugged me so tight. And she was like, Jeanette, you changed my life. And it truly was just listening to her and giving her options and talking about what she felt most comfortable with.
Right.
But don't be afraid to ask these questions, y'all. This is available for you for a reason. Going back to the testosterone cream, not everybody can afford the pellets, which is such a bummer that they're so expensive because they are so helpful. But honestly, the people that this change affects the most, right? And they find a way to pay for that. They usually will tell me, you know what? It's worth it. It's absolutely worth it. And I would do it again. But as far as doing something that's not as expensive, there is the testosterone cream. Like I mentioned earlier, the FDA in the United States does not approve testosterone replacement for females, which, like you said, is bullshit, right? So options moving there or going forward from there is the compounding pharmacy, where we could do a compounded testosterone cream that you apply to your inner arm or inner thigh once a day. There is a sublingual testosterone pill, basically a tablet that you put underneath your tongue, and it basically dissolves and it gets through the bloodstream that way. And then there also is, like you mentioned, the testosterone injections. These are not my favorite. First of all, it's testosterone cypionate. So that means it's in an oil-based, and that can actually increase your risks of cardiovascular events. And also it can also do things as far as your cholesterol, it can make that go up. And I have seen a few LFTs or liver function tests go up with that form of testosterone replacement. So I tend to not recommend that. The other thing that I recently started doing that is just honestly complete genius, and I did not think of this. This was on a physician that I follow who does just menopausal medicine, but she started prescribing like androgel, which is men's androgel that we give men, that's covered obviously by insurance for them. But she prescribes that, and she just does 1/10 of the male dose. Right. So that's hard, right, to obviously measure out. But on the androgel, it actually is a little bit easier as far as on the pump to kind of measure that. And I'm getting that for women at a pretty affordable rate by using like the GoodRx coupon. I don't know if you've ever heard of the GoodRx coupon.
Excuse me.
Right? Like whoever came up with that is also a genius. So GoodRx is a company, goodrx.com, that you go and you can put in any medication that your prescriber has prescribed for you. And it can actually give you a cash pay price because like we talked about last time, insurance will charge the shit out of you.
Sucks.
Yeah. And you could pay a shit ton of money for a prescription when you could just pay cash and pay the pharmacy straight up with that coupon and get it for like, what, 20th, 30th, 50th of the cost, right? So I absolutely recommend GoodRx, but you can get GoodRx pretty cheap or get an androgel pretty cheap through that GoodRx. So I've been using that a lot.
Okay.
It's working great. My ladies are getting results. They're feeling better. So, and they're able to get it.
We love this.
Yes.
Okay. So we spent a lot of time talking about hormone type replacement. What about non-hormonal options?
Yeah. So there actually is quite a bit of non-hormonal options. So there's a brand new company out, and I say brand new, they've been out for a while, but they're basically now just being buzzed about. But it's a company called Bonafide. Bonafide is a new company that has come out that came out with a whole new line for perimenopausal females for the symptoms that are caused by these hormone fluctuations. The newest one that has hit the market is a product called Thermella. Okay, Thermella, what it does is it hits a receptor in the brain that when it is attached to it, it doesn't allow you to have hot flashes. How cool is that, right? And these are all natural products, right? Like curcumin is in it. Can't remember all of them, but there's quite a few products that are actually in this I can't really call it a medication, but this supplement.
Supplements. Yeah, they're all supplements.
And they have been really successful at helping with hot flashes. Studies show that within the first 2 weeks, women are getting results, right? No side effect either, right? So that's huge. There is another drug on the market that's actually a prescription that does the same thing. That prescription is called Veoza. Veoza has been on the market probably about a year, right? Maybe a little bit over. Don't quote me on that, but it's been around for enough that I'm educated on it. And that prescription, I can be honest with you, I've never prescribed. Let me tell you why. It works in the brain, just like the Thermella does, but you have got to get a baseline lab that tells me what your liver function looks like. This drug can affect liver function. And so you have to do frequent lab checks in order to make sure that it's not affecting your liver. And so I tend to stay away from things like that just because I'm not great at making sure that if I prescribe that to 10 different women, am I making sure that each of those women are getting that lab drawn when it's supposed to be drawn? That makes me a little on the nervous side, right? Mm-hmm. Do I think it's a great drug? Yes. Do I think it has a place in the market? Absolutely. Do I think that the patient has to be their advocate and bring this up to their physician and know that, hey, in this amount of time, I need to go get my blood drawn? Absolutely. Right. So you got to advocate for yourself if that's the route you want to take. Right.
Just quick sidebar on Bonafide.
Yes.
It really is all natural because I got a sample from work to give to my mom.
Yeah.
And I had put it on my counter.
Oh, God, this story.
I went to work out, came back. And when I came back, the medication was no longer on my counter.
This one was the one for hot flashes.
Yes. Mm-hmm. Another one for hot flashes, not the one that you just mentioned.
Yeah, it's a different one.
It was not on my counter. It was now on the ground with the pill box that was now opened with a dog that was just sitting there looking at me.
She ate all of them, guys.
No, not all of them. She ate 13 of 14.
Oh, 13 or 14.
So what do I do? Excuse me. I call my vet and say, hey, my dog just ate some pills. And they say, we cannot talk to you. You have to call poison control. Animal poison control.
There's an animal poison control, y'all.
Absolutely. So I call animal poison control. Mm-hmm. And before we can even say anything or discuss anything, she says, this will be a $90 consult.
This dog has been so expensive for you.
I know. God. $90 consult. So the $90 consult turns into me saying my dog ate 13 out of 14. I can't remember the name of the Bonafide product.
I think it's for Stella.
I don't know. Regardless. Yeah. And so the person said, okay, let me go do my research. Mm-hmm. So she leaves for about 5 minutes, comes back and says, hey, great news. Your dog ate something really very natural. You don't have to worry about anything. However, if your dog starts to throw up and throws up more than 7 times in 30 minutes, you should call your vet.
So you spent $90 to make sure she was okay.
It was a 10-minute call that cost me $90 and my dog was totally fine. No issues. So if Paisley can eat 13 out of 14 pills and be living her best life,
yes,
I think it's a good option.
So this product, I remember now it's called Relazin. Okay.
Yes,
Relazin.
Relazin,
That was the initial one used for hot flashes, and it works in a little bit different way.
Yeah.
But Paisley, right, wanted to get rid of her hot flashes. Maybe you need to listen to her.
Ugh. I think you're just hungry, like chronically hungry.
Chronically hungry. Oh gosh. So like I mentioned, Relazin was their first one. And then now they've come out with one that actually works better for hot flashes, and that is the Thermella. There's another one that I think is important because, like we mentioned, low libido is a huge factor with menopause and perimenopause. And so hormonally, we offer estrogen and testosterone for that. But there are some women that don't want to take hormones, and that's okay, right?
Or can't.
Let's just say that.
I should say that too. Or can't. And there's reasons why you can't. We'll get to that too. But there's a new one that they have called Restella. And this is supposed to stimulate for support for increased satisfaction. So it helps with orgasms, it helps with libido, and it actually helps with more of the sensation as well. That's 2 tablets a day. And I've had patients report back to me saying they can only take 1 tablet a day because it overstimulated. So, and that's a natural product, right?
Wow.
So I honestly am a huge fan of this Bonafide line. I think we've talked about before that they also have a vaginal dryness option, and that's the Reverie. They have a new product called Reverie Plus, and the Reverie Plus is basically hyaluronic acid with vitamin E oil. And that combination, they did a head-to-head study between that and vaginal estrogen, and there was no statistical difference between the two. They actually got improvement with both arms of the study. So if you are anti-hormone or can't take hormone, or you're afraid of the hormones, even after this talk, you're still afraid of the hormones, then I think the Bonafide line is a really great option for you that I want you to look into. There's also a 25% off coupon for that. You just got to message me and I can send you that coupon that you can get. Okay. Another option that a lot of women use is going the SNRI route, right? The antidepressant route. And those are going to be medications like Effexor, Cymbalta, Pristique. These medications have been proven to help with hot flashes. Also, obviously, the anxiety that comes along with perimenopause. So I have a lot of patients that maybe can't take hormones or don't want to take hormones that have gotten some significant relief with these medications. And you don't need a high dose with these. I usually can get control over these symptoms at lower doses. So I think that's definitely an option to talk to your provider about.
Definitely.
There also is cognitive behavioral therapy. I know we've talked about therapy in the past, but getting a therapist to try to get you to understand in your brain what is happening and how to kind of help you through that. So maybe breathing exercises to help you through that hot flash. But yeah, I think that CBT or cognitive behavioral therapy can absolutely be successful with these ladies. There also is something that I think is so crazy that actually one of the docs I work with recommended it the other day, and I had no idea. But oxybutynin, is also known as Vesicare. Right. It's used for urinary incontinence. So the women that are having issues with peeing on themselves when, not so much when they sneeze, laugh, or cough, but more of like an urge incontinence where if you don't go to the bathroom, you're going to pee yourself, right? Side note, ladies, if this is happening to you, bring it up because this is very common. Everybody's embarrassed about this, but I probably see 20, 25 people a day, and at least 5 of those women we're talking about incontinence. So please bring it up. But going back, a medicine that's commonly used for that is actually been proven to help with those vasomotor symptoms or the hot flashes and the night sweats. I just thought that was so neat. Yeah. I didn't know that it did that.
No.
Yeah, so that was neat. The other really good options that are out there that a lot of people don't really talk about are that like black cohosh. I know that there's also an over-the-counter option too called Estroven, and that is like a phytoestrol. It's basically a plant-based estrogen that is found. What's cool about those is you don't necessarily need the progesterone along with that. You could just take the Estroven or just take the black cohosh to get improvement with those symptoms, right? So I think that those are going to be extremely helpful for our ladies that basically are having these symptoms and are fearful or just can't take these hormones options.
Right. So actually that kind of brings us to who should consider actually using hormone replacement therapy.
Absolutely. So it comes down to a good history with your patient, right? What is their age? What is their past medical history? Do they have any history of DVTs or deep vein thrombosis, also known as a blood clot? And was that blood clot brought on by something? Was it brought on by a fracture of your leg? Well, that actually does not cause you to have a risk, right? If it was a blood clot that you got after you broke a leg and your leg was broken and you were sitting in the same position for a while, that actually does not increase your risk or make you not a candidate for hormone replacement therapy. But if you have a blood clot that just happened out of nowhere, then yeah, sorry, I would not recommend this for you, right? Also, if you have history of breast cancer that is estrogen positive or progesterone positive, then what that means is that actual cancer itself actually had a receptor site on it that estrogen fed that cancer or progesterone fed that cancer, then I do not recommend hormone replacement therapy, right? In fact, most women, even if it's ER/PR negative, right, we still don't recommend hormones, right? I don't know if you do, but I don't. A lot of times I don't recommend it.
I think it's probably important that we talk about why people are scared of hormones.
Yeah.
And it all goes back to a study.
Yes,
that
absolutely.
has been debunked multiple times.
Yeah. And I can talk about it. It's called the Women's Health Initiative. And it was a study done in the 1990s, like late 90s. And the women that were in the study were like 60 and up, right? So these are women that have been out of menopause now for probably 10 years, right? And these women were given two forms of hormone replacement therapy. We had two arms of the study, right? We had one that was Prempro, which was estrogen with progesterone, which was synthetic. And then we also had the Premarin, which was just estrogen alone. These are obviously the ladies that had a hysterectomy. As they got through the study, they kept doing it. And then around in 2002, media came out. There was a huge halt. They were like, everybody, if you're giving your patients hormones, you need to stop them now, right? Because what they found was that the Prempro arm, which was the estrogen with progesterone combination, right? Which was a different type of progesterone and estrogen that we're giving now, just side note. They found that there was an increased risk for invasive breast cancer, right? We were like, holy shit. We've been giving this to so many women and now we have caused them to have breast cancer. That's freaking scary, right? So everybody stopped their hormones. Right? These are probably like our grandmother's age, right? Possibly our mom's age. So everybody now is fearful at this point of estrogen and progesterone. And so physicians, PAs, NPs, everybody stopped giving it. But the true study, right? The actual results of the study were that 4 women out of 1,000 women over 5 years got breast cancer.
Which I would expect.
And who knows if they would have got breast cancer anyways.
Exactly.
Right? And they actually, that was in the Prempro arm, right? The Premarin arm was able to keep going because they didn't find those women, they didn't find any women to get breast cancer. So actually, the Premarin arm actually showed that the estrogen protected these ladies from getting breast cancer. What a spin, right?
Yeah.
But all we heard was that Prempro and hormones, right? Hormones in quotes, caused breast cancer. So don't give it, and do not prescribe it, and be fearful of it.
And how damaging. Damaging. I mean, we're still talking about it. And it was over 20 years ago. It's very, very upsetting as a woman.
Yeah.
Because, and this is the feminist in me coming out, but would it be the same outcome if we were talking about male hormones causing testicular cancer, causing prostate, like that's,
of course not.
No, we would not be where we are now.
No.
So that was just an aside that I feel like we needed to talk about.
Well, yeah, because that's the question I get every time.
Exactly. The pushback that I get
is breast cancer.
Is breast cancer.
Every time.
Always. Yeah.
Every time. And I think it's important that you as a female know your risk. Absolutely. I feel like this is a conversation you need to have with your provider. I feel like that you need to talk to your provider about this Women's Health Initiative. I will put a link to a really good video about this on our Instagram. I want every one of you to listen to this because it will open your eyes. It's done by a gynecologist and it is really impressive, actually, what that one study changed for the lives of how many women? Thousands.
Millions.
Moving forward.
Yeah. It's crazy. Okay.
So let's kind of talk. Do you want to talk about the risks that come with hormone replacement?
Yeah, absolutely. So I think risks are important because like we talked about last time, there are risks with anything we prescribe, right? So if we do an oral estrogen, there is the increased risk of cardiovascular disease. If you were ended up to have breast cancer, right, while you're on hormones, your hormones are going to be stopped, right? That doesn't mean that hormone caused your breast cancer, but if it's an ER positive or a PR positive cancer, it could be feeding that cancer. So obviously that would be something that we need to talk about. And then also just the side effects, right, that can happen. Testosterone, right? Go for it. You see these all day long.
Hair growth.
Everywhere. Except on your head.
I know. Potentially hair loss on your head.
Right.
You can have acne, especially if you had acne as a kid. There's a higher probability for you to have that acne issue with testosterone replacement.
Right. But can we also talk about that if you get that lady in optimal range, they're probably not going to have all of these side effects, right? It's when they get overdosed, right? Or when it's too high and it's out of their recommended optimal range that there's more side effects. So I don't want them to be afraid of the testosterone.
Definitely don't be afraid of testosterone. Yeah. And we also have medications to help with all of these side effects.
Well, sure. Yeah. Absolutely.
But we have to adjust doses according to side effects, according to how someone feels.
Yeah.
But those are the big ones. I really feel like we're women.
Yeah.
So the hair growth one is really like the
hardest
one that really gets people.
Yeah.
So
also like the abnormal bleeding that can happen, right? So, if I put you on an estrogen, no matter the form, if it's a pellet, a cream, a pill, a patch, whatever it is, and it's not completely balanced with that progesterone, or maybe you skip a few doses on accident at night, you go out of town, you forget your progesterone at home, there's a good chance that you're going to come to me with spotting and bleeding, right? First thought, anytime somebody Googles postmenopausal bleeding, what do they have, Brittany?
Cancer.
They have cancer. Every time. So do not Google it. Just come see me. Because a lot of times it's literally just an imbalance of that hormone. We've got to double up the progesterone for a week or two, and that usually fixes it, right? Yes.
Yeah.
Okay.
Yeah.
And so like Brittany said, that we monitor your symptoms, monitor your side effects, monitor your how you're feeling. And we can also obviously monitor with blood work too. Usually if I start you on hormones, I'm going to repeat that testosterone level in about 6 weeks. And I think you do the same. Usually 6 weeks, I want to see that testosterone has met optimal range from the 0 that maybe you were at before. And I want to make sure that you're feeling better, right? Are those symptoms that you came to me 6 weeks ago, are they now gone? If they're not all the way gone, then we need to make some adjustments. If they are all the way gone and you're feeling like a rock star, then I don't need to make any changes, right? So I think that guidelines are going to be per patient, right?
Definitely.
So there is a hypothesis that basically the sooner we start hormone replacement therapy, so the sooner we catch that estrogen, progesterone, testosterone falling down, the better your outcome will be cardiovascularly. There are studies currently going on about not only but cardiovascular disease, but also the effects on our mental clarity, right? Dementia, Alzheimer's. I don't know if you saw in that documentary how most people that are diagnosed with Alzheimer's are female, right? Or a high percentage are female, and they're usually obviously of older age. I think they're doing a study on basically the lack of estrogen and who had estrogen, who did not have estrogen, and the dementia that obviously ensued after that. So I think there's some pretty amazing things that are about to hit, that we're about to really open our eyes to hormone replacement therapy and how great it can be.
Interesting.
I know.
So interesting.
I know.
You know that before I was a PA, I did pharmaceuticals.
Yeah.
And my medication was supposed to help with one thing, but an off-label thing was supposed to also help with like dementia.
Oh, really? What a hard disease, man.
Yes.
My grandfather had dementia, and it was, I'm sure anybody listening, you probably know somebody or has somebody that has been affected by this, but dementia is hard.
It is.
So hard.
Yeah. But I just want to tell you that my medication, the compound that it was, I should say not, I wouldn't call it a compound, but regardless, it was dextromethorphan.
Really?
And an old antiarrhythmic.
So dextromethorphan is a cough medicine.
That's Robitussin, y'all.
Yeah.
And an old antiarrhythmic.
And an antiarrhythmic is a medication that's given when your heart beats out of normal rhythm.
My point is, I don't know how that study went. But I think
did it work?
No, I think hormones have a much better chance of helping us on that end. But.
And honestly, ladies, if you're still confused after this podcast and you're still worried about hormones and you still have questions, please don't hesitate to ask. And then honestly, send us a message because we've got some really good videos that are really informative and basically showing their true studies that have been done on this. So
yeah, I also get the question of, okay, how long do I have to do these hormones? Do I really have to do I do this for the rest of my life? Or is this going to hurt me if I do this for the rest of my life? Or if I stop taking it, are my symptoms gone? Loaded question, y'all.
That is a loaded question. And honestly, there is a really good society called the Menopause Society. And the recommendation on there is to, after 10 years of using hormone replacement therapy, to take a hiatus to see how you feel. Ladies, do not just stop these. You will feel just like you do now, right? If you're having those symptoms. So tapering off is the key, right? So say you're started on 0.05 milligrams or 0.5 milligram of estradiol, right? The last thing you want to do is just stop that patch, cream, or pellet or pill. And you want to actually taper off of it, right? And that's with all of these hormones. You want to taper off so you do not feel that complete without, because that's what's going to make you symptomatic. But honestly, there's no real recommendation out there on how and when and where to stop. I mean, I know you've got a couple ladies that are in their 80s that come and get their pellets, right?
Yeah. And they're fabulous.
They are fabulous. And their skin probably looks awesome.
Yeah. Jesus. I've been seeing this new thing about estrogen topical for the face.
Yeah, I prescribed it the other day.
Did you?
And I read the studies on it. There is a company called Muesli, which I think I've told you about.
Yeah.
Muesli, I actually get my face stuff from them because I was dealing with some melasma, but that's darkening of the skin from the sun. But yeah, I actually
wear a hat, Jeanette.
I do. Oh, speaking of hats, our Lube Tube hats are coming. Get ready. They're so freaking cute. But anyways, no, estradiol. And it's called actually estriol. So it's a different form of estrogen that you apply to the face that can help the softening and the fine lines. So yeah, pretty cool.
Yeah, I love that. Is it time for Slippery Solutions?
No, Slippery Solutions with B&J. Still don't have a song.
I don't know.
That my mom the other day was like, Jeanette, my favorite part is Slippery Solutions. I was like, oh, that's good.
I mean, it's a good. It's nice to get feedback from people and questions from people.
Yes,
and things that are related to
people are actually listening to us.
I don't know. Okay. Question 1.
I'm ready.
My best friend, no name here, got testosterone replacement.
Okay.
But it has now changed her voice.
Oh, yeah.
Is this normal? And should I tell her?
Oh, this is a tough question. Can it happen?
Yes, 100%.
My question though is, what's her dose? Right? Is it too high for her? Maybe. But there are studies that show, does that change? I think I read in a study that it doesn't go back to normal after you have actually used the testosterone. But this is why you need to go to somebody who draws your labs. It's following you every 3 months, that is doing what they're supposed to do. There are a lot of pop-up shops that do these hormone replacement therapy that are just throwing these incredibly high doses of testosterone at females with no follow-up. There's a lot of online options that you can go and get hormones through online. Then you're never talking to anybody or actually getting an exam or anything like that. So yeah, I mean, can it happen? Sure. But I think it would take extremely high doses.
I will tell you that I have seen it in some of my patients, and it's not a drastic change.
Yeah.
And it's usually they'll come in and say, oh, my husband says that my voice has changed a little bit. And maybe I can hear it a little bit. And I will immediately lower their dose.
Yeah.
And I have seen some where it improves.
Oh, good.
For them. Because I mean, I don't, if I haven't been seeing them for an extended amount of time, I don't know their voice and the small changes.
Sure.
So I've had both people that feel like it has improved, and then some people that, like you said, where that's kind of where their voice, but that's, I rarely hear that side effect. That's not one that I tell people when they're first starting hormones.
Me either.
Because I don't see that often unless we're at higher levels that could potentially do that. But there's always those one-offs. But back to your question of, should I tell her?
Yeah.
She's your best friend.
Yeah.
If you feel
would tell me, right?
100%.
She tells me things I don't even want to hear about myself.
Yes. Well, you've done the same for me. Thank you.
You're welcome.
Thank you.
Anytime.
So yes, can this happen with replacement? It's not as common as other things.
Okay.
Should you tell her?
Yeah.
Yes. She's your bestie for the restie.
Mm-hmm. Anything else?
Question 2.
Oh, got another one.
Recently, I started an antidepressant and now I feel like I can't climax.
Oh, very common.
How do I
This is one of those untalked abouts, right? I got on an antidepressant because I was feeling sad and I'm overwhelmed and I have a lot going on, or maybe I'm postpartum and I'm needing that for that. And now I want nothing to do with sex. And even if I did have sex, there's no way I'm going to have an orgasm. Okay, well, that's a problem, right? And you need to talk to your provider. There are lots of options out there that actually don't cause that, right? So there are the old school antidepressants on the market that very commonly do this. One of them is Lexapro. Another one is citalopram or Celexa. Zoloft has also been proven to do this too. Options out there that don't do that are going to be, it's a different class of drug, but Wellbutrin can be very helpful with this. Another one that's one of my favorites on the market is called Vibrid. It does not have that side effect to it. But I think this is a talk that you can have with your provider. I actually listened to a talk or a podcast the other day about this Bonafide supplement. And that one that we were talking about earlier that helps, I think it's the Rostella. It actually can help with patients that are on antidepressants to help them get that libido and that orgasm back if they're on that. So I think that's another natural supplement that you can look into. I also have some ladies that add on a testosterone cream to help with the libido portion while they're on the antidepressant. And that helps too. So I think you've got some options there, hon. You need to go talk to them, somebody.
Cute.
Yeah.
Go yield. Okay, so I let's just bring it all together.
Bring it all together.
I think that everyone needs to know that these symptoms are a real thing that all of us go through. Now, there's different severities.
Sure.
There's some people that say, I've never had a hot flash in my life. But the mental clarity or brain fog, I should say, I feel like that's
a
universal.
Big one. Yeah, joint pain, the night sweats.
All the things.
You know, and I think this is important that we also say, like we've said many times, this is normal, but that doesn't mean we have to live with the normal, right? There are hormonal and non-hormonal options that can absolutely help you through this transition. And we need to not look at menopause as a bad thing. We need to embrace it because we're all going to go through it and find our way to basically get ourselves through it in the happiest way, because your life is not over just because you can't reproduce anymore.
No, you haven't gotten there yet, but there's some good years.
I can't wait. Can't wait.
Yes. So there's many different forms of replacement that can help each and every one of us.
Absolutely.
And whether that's going to be hormonal or non-hormonal is totally up to you.
Right.
But if you want the hormonal route and your doctor is not really willing to do this for you, just know that there are other providers. So if you need to move, then you need to move. You need to have the quality of life that you deserve.
Absolutely. If you go to somebody and they say, oh, you're just getting older, it's time for you to find a new person. It's that simple. Like if they're not going to listen to you and they're going to push that off, go find somebody who will listen to you because there are options out there.
Preach.
All right. Well, thank you, Brittany.
No, thank you, Jeanette.
Absolutely. I hope y'all learned something today. No conspiracy today, though. That's kind of weird.
I could get into some stuff.
Okay.
But I think we've run out of time.
Okay. Well, y'all have a great day and look forward to hearing y'all's feedback. Take care. Bye.
Bye.
The information provided in this podcast is for general informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition. There is no provider-patient relationship formed. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. The hosts, guests, and producers of the podcast do not assume any liability for the application of the information discussed. Reliance on any information provided by this podcast is solely at your own risk.